Assalamu alaikum, everybody. My name is Waqar Ahmad. I'm an interventional cardiologist in Jeddah, Saudi Arabia. And I'm welcoming you to this session with Live in a Box from Baylor College of Medicine, St. Luke's Medical Center, Houston, Texas. And along with me are my co-moderators, Dr. Adel Atribi from Egypt and Khalid Al-Marri from Kuwait, and along with Dr. Silva from Houston. And he will now introduce the cases and the operators. Dr. Silva.
Good morning, Houston. Good evening. So this is a case where I'm presenting two cases today of valve-in-valve, where there were therapeutic dilemmas that were posed to the team. Here's the team that we have here in Houston, which is, of course, there are a lot of more people, but we did have the intention initially for Dr. Coselli, who's our cardiac surgeon, and Dr. Simpson, who's our heart failure specialist, to be present here today. But unfortunately, in this new world of Zoom, sometimes things don't work appropriately. So regardless, I'll jump into the cases. So needless to say that we're all here today because there's a heart team. And the heart team has expanded tremendously into the not only the realm of structural heart disease, TAVR, but also into the realm of coronary revascularization. This is a case of a 77-year-old woman with severe aortic stenosis. She had an AVR in 2012, so about 8 years ago, with a 19 Carpentier Edwards Magna Ease. And this is something we see over and over again, small frail ladies with a small annuli that get small valves. She was admitted to an outside hospital and had her own stress test with unbeknownst stress test with a hemoglobin of 6.5. So essentially, she was transferred over to us after being stabilized, and we got the gastroenterologist to see her and clear her for a valve, and we decided that it would be best for her to have her AS fixed. So this is the baseline echocardiogram. You see here that there's severe AS with a mean gradient of 46, aortic valve area of 0.6. Point here that you see the stroke volume index was quite low originally, with a cardiac index of 2.83. So keep that in mind, because the gradient being 46 at baseline, this is going to be relevant in the next part of the presentation. So coronary angiogram, this patient has had bypass surgery. She had a lima to the LAD and an SVG to the diagonal. You see here the valve, the Magna Ease, that's quite well seen in fluoroscopy. All the other vessels were patent, so coronary disease was not her problem. You're going to see how now the lima coming down. So procedural planning is key, and I'm going to ask Dr. Conera to jump in a second and about what to do with this kind of patient. The main concern that we have is, of course, coronary occlusion to avoid severe patient prosthesis mismatch. And also, in this case specifically, we were very concerned about annular rupture. This patient is very frail, with moderate to severe frailty, very thin with a low BMI. So, Dr. Conero. I think you're muted. Dr. Conero? Well, I think he's muted, so I'm just going to keep going here. We essentially looked at the distance between the, can you guys hear me?
Yes, we can hear you.
Perfect. So we saw the distance between the coronaries and the valve. They're above 3, so non-ideal. Ideally, it needs to be above 6. But most importantly, if you look down here in to the right side of the screen, you see that there's about a 10.3 millimeter deep in the LVOT chunk of calcium. The access was pretty good. So technique of valve fracturing is well established now. One can see here the Edwards Magna Ease. We do need to have a bigger balloon, in this case with an ID of 17. We knew that we need to use a 20 balloon going up to about 18 atmospheres based on previous bench testing to break the valve. So we, as listening to the previous panelists here in the presentation, we do the same. We have a very careful examination under CT of the access site. We do put a pacemaker routinely, especially for core valves, and we decided that this patient would be better with a supraannular valve. So we get access here. Our prime site was the left side. We've worked a lot with the Manta device. We found that the ProGlide works really well, and sometimes even better than the Manta device. So we went back to the ProGlides. So we put two ProGlides, perpendicular ProGlides. And you're seeing here the two different techniques. Myself, I pull back and I turn, and then I deploy. And the second ProGlide is going to be done by Dr. Simpson, who unfortunately, again, cannot join us right now.
You can't still hear us, right?
Huh?
That's okay. You carry on. I'll pitch in a second.
Awesome. So here's Dr. Simpson he goes in angled, and you see that he gets he pulls back, and then he does another confirmation that he's against the femoral artery. And then, and this is kind of standard. I know everybody in the audience has done this many times, but I just thought it was quite interesting. We chose to use an 18 sheath so that we didn't have to be dealing with the inline, especially when you have tortuosity. We find that that's very helpful. And then those are the hands of Dr. Coselli. We have him cross the valve almost every case. And most operators, when they come to my lab, they're like, wow, your surgeon crosses the valve. Yeah, he does. He's pretty damn good at doing this. So those valves sometimes can be hard to cross because they have, you have the post, you have eccentric. So it takes a little time, but we usually, he's going to cross right now. And we're kind of careful to make sure that we're not going against or under the mitral, apparatus. So here we're crossing the valve, and now we put a long J, and this is Dr. Simpson, and we put in a pigtail catheter inside the LV to exchange for. In this case, we thought about using a Lunderquist, which it's a very stiff wire. I thought the Lunderquist was going to bias us to the outer curve and then make it difficult to deploy the core valve. So we decided to go with a Safari wire, which is a less stiff wire. And it's very friendly inside the ventricle, especially for those little ladies. It's kind of a weird, there you go. Now it's a little bit better. And you see that the Safari wire took us very much into the middle of the valve, which is what we wanted. So we routinely have our patients under general anesthesia. I know this, Dr. Pinero, go ahead.
So, sorry, there was some kind of technical issues before. Looking back to the echocardiogram and the parameters which Dr. Silva was showing earlier, if you could see this lady was in atrial fibrillation, and with every beat, her stroke volume was different, which makes extremely difficult to assess the severity in these patients. With a smaller valve, every other beat, you have a smaller stroke volume. And going back to the initial gradients he was showing, the mean gradient went in every alternate beat close to 72 mmHg. So it actually shows like how significant it is. So when they go back into atrial fibrillation, when you start to assess all the 10 beats and average them, and we got like close to like 44 as a mean gradient, which is still high. But what really matters is when you have a stroke volume higher with an ectopic beat, that's what you got to take, but you have to take the same LVOT after the ectopic beat or a bigger stroke volume to do the dimensionless index. Now coming back to what I actually see in this particular case is we really have to make sure if the coronaries are really not closing off because of the smaller annulus, and the distance from the ring to the coronary ostium should be at least like 6 millimeters. So what happens is when you're leaving another valve inside, the bioprosthetic leaflets can potentially close the low originating coronaries. And those are the things, like, we look forward before Dr. Silva, Dr. Coselli, and Dr. Simpson go ahead and deploy it. Go ahead, Dr. Silva.
Okay, so the gradient was quite significant. Dr. Coselli, can you hear us, and can you?
I can hear you, yes.
Perfect. So we do this very diligently. We floor every valve to avoid any kind of under expansion. So now we're going to insert the valve. Dr. Coselli, go ahead.
I think it's pretty straightforward at this time. We've got the primary access wire across the valve, and in here we're just advancing it up the sheath to protect the iliofemoral system.
And we're making sure the port is turned to 3 o'clock, so that we have a good alignment of the post. Although this is not a native valve, but we still do the same. If you look at the deployment, we go slow, and we do have quite a bit of a coordination between two operators. We do this, 4 or 5 times a week together.
Even with rapid pacing, these valves can move around a little bit, so slow, fine adjustments of the position are quite helpful. You can probably see my
Go ahead.
You could probably have seen my right hand just move just a little bit. These valves sometimes have a tendency, because of the energy in the system, to advance slightly.
So we decided to go in with an 18 balloon because of the issue with the calcium, and we wanted to see if we're going to need to crack this valve or not. We were very concerned about that calcium again because we've seen this. So this is a technique to inflate the balloon inside the valve. You do need the intelliflator, and you need a syringe to fill the balloon. So we're pacing quite rapidly at 180, making sure Dr. Coselli is pacing, Dr. Simpson is there, and I'm at the balloon. So we're filling in the syringe real fast, and then go ahead and crack the valve, or not crack, but inflate the balloon very, very nicely. You see here that the 18 balloon, didn't do a lot. We did measure the gradient afterwards to see what was the gradient, and the gradient was still high. I think the mean gradient was still about a 20 something. So we decided to say, well, this is the 18 balloon is not helping, so we just need to go in with a 20 balloon. We decided not to use the intelliflator, just use the manual inflation of the 20 balloon. And this is what we got right there and then in the CVOR in the lab with a mean gradient of 3. We're happy with that, and we essentially did a angiography to make sure that everything was preserved, and it was. And we closed with a ProGlide. And this is us kind of very, very happy with the result. However, if you look at the day after, and then Dr. Conero has mentioned that, you see here that the gradient, the DOI is a lot better, it's 0.54. The cardiac index is a lot higher with the stroke volume index that's now is normal, but the gradient is still not satisfactory. We opted at this point to observe this patient, and if need be, we bring the patient back for a valve cracking, and we can discuss this in a little bit. The second case we have is an 89-year-old with a history of lung cancer, COPD. He also had a kind of a small valve for big annulus. This was done in 2003 and an outside facility. He came in 2019 with no symptoms of heart failure and an EF of 60 with a DOI of 0.31. At that time, he had a healthy ventricle with LV stroke volume that was quite high, and the cardiac index was 4.22. Coronary angiogram shows here that he had normal coronaries this time. And so now, after 2019, he had new onset heart failure, His gradients went down, which are consistent with his cardiac index and stroke volume going down. And I'll let Dr. Conero comment on the TE that was done at that time. And here's some images of the TE. Go ahead, Dr. Conero.
So the interesting thing in this patient is you can see his annulus is quite big, and they choose a smaller one. You can see the annulus areas and everything, which is close to like 620. One would choose a valve close to like 29. But again, the valve was chosen smaller to be like 23 valve. And I was looking at like the transgastric views again, like it's very, very difficult to look at the bioprosthetic valves, which are a little older, to see like how good the valve excursions are. So in this particular case, you can see that the valves are opening well, but there is still some thickening. Then it clearly says that yes, there is some degree of aortic stenosis, the valve leaflet restriction. However, there is significant patient process mismatch. That keeps your dimensionless index always less than 0.35. I mean, in this case, it's like 0.31, which made us to decide, like, what can we do to lower that mean gradient to expand this valve. Dr. Kosali can further say, like, he would have done like thousands of these cases with expanding the roots and other things. What do you think, Dr. Kosali?
Well, I think as an 89-year-old previous lung resection, COPD in the rest of the lung, that an open operation, this patient would be exceedingly difficult, if not impossible, to recover from.
Okay, so a stress echocardiogram, we showed that this was significant with a mean gradient of 41. So we concluded as a team that this was more of a patient-prosthesis mismatch, but some degree of valve degeneration, that this patient would probably be, benefit from having a new valve. So we decided to go in with a plan of fracturing this valve. We knew that there was the annulus was a lot bigger. Whenever you're going to fracture a mosaic, or you have to upsize, so if you can do a valve in a mosaic, usually the valve app tells you to go with a 23. We opted to go with a 26, one bigger, and then use a true balloon, a 26, by increase it to about 10 atmospheres so that we could fracture the valve. So here you see a rendering of the CT. In the middle here is what a 23 will look like. In the side here, what a 26 will look like. And again, like Dr. Conero said before, we will look at the distance from the frame and to the coronary. Dr. Koseli, you want to comment about the AAA, about the access?
We not infrequently encounter some of these patients with moderate AAA inferior abdominal aortic aneurysms. They don't really pose much of a problem. Most of the sheaths place us above the inferior abdominal aorta, so we're not trigressing that area a great deal through these procedures. And they're certainly not great candidates to do anything to that aneurysm until the valve situation is straightened out. This particular patient at this age, we would have just observed it anyway. But from a technical standpoint, it really is not an impediment to getting the sheaths and the wires, et cetera, through this area safely.
So this is a procedural video. Again, this is Dr. Costelli standing back there, kind of putting pressure. Let's go. This is a 14 French sheath. We did have some calcium in the iliac, so we opted. It was not circumferential, but we wanted to make sure that the 14 sheath would go easily. So we just use the dilator to kind of palpate the artery and see it. So it went really easily. So we were very confident that the sheath was going to go and that we would have a good position. Dr. Sell, in terms of crossing the valve, go ahead.
We're just trying to, normally what we're able to do is just use the straight wire to get a feel for exactly where the flow is across the valve. Of course, that's the opening, and then you time it into in a situation where it's in systole and you cross the valve.
So we're putting the Edwards valve in, and this is kind of a standard thing that we all are very used to. But here there was a little more difficulty because of the calcium, but we were able to traverse it nicely. Dr. Simpson is now mounting the valve in the descending aorta as usual. And we're going to be coming up pretty soon. and now it's the inflation. So again, we use two vials, one with the volume. Dr. Simpson is going up again with the balloon. You see here the balloon going up. And then you have to go to 10 atmospheres with fast. It's kind of a long pacing run, but you see here that at the end, you're going to see in a little bit, the balloon expands completely, and you do have, visual fracture of the valve. It's hard to see in the mosaic the fracture in itself. So we went all the way to about 12 atmospheres here. Then we get the balloon out, and we did get a good result. And Dr. Cornero, you want to talk about the gradient and and how it looked like? This is right after the deployment of the valve, before the balloon. Go ahead.
Yeah, you can. One can see like clearly the valve is still adherent to the ring, but it's not like expanded well like what we expected. This is the balloon. You can see like the very well described, very well alluding, and then like how much it's really expanded out, making these stent struts like move out of the post, showing that like this is stretched and cracked. And finally, you can see the dimensionless index, and the mean gradients is like 5. So this is the very well done case, and yeah, good work, everyone.
So this is a mean gradient that next day of 13 with a DOI of 0.57. Remember, it was 0.31. His heart failure symptoms improved. Dr. Rossetti, you want to conclude our approach to the VIV?
It just means a great alternative for these high-risk patients. And I'll take an example. This last patient had a tortuous aorta and some concerns about the size and calcification of the iliac artery. And we obviously chose to go up to the left side. But this particular device has a sequential balloon and valve that once you're in the descending thoracic aorta, you take it from a sequential position back into a coaxial position, which allows for a lower profile. So for certain valves such as this, where you want to do some fracturing this type of valve, I thought it would, it's an excellent choice. There's some limitations though to all of these various devices. This particular device we used in the last case with the tortuous arch of the aorta does allow for the upper end of the device to be pulled into an angulation, which helps transgress a Gothic arch. But I still think, regardless, for valve in valve, you just have to select the patients properly. You have to plan the operation very, very thoroughly, and respect the specific aspects and potential issues with regards to the valve that you choose to use.
Okay.
Thank you very much.
That's all we have.
Thank you very much for showing us two great cases of valve in valve, starting from the preparation and to the procedure. The question I really want to ask all the Houston people, but I can't ask, is why are the best players from Houston are leaving your teams? But anyway, we'll stick to multidisciplinary cardiology. I mean, Deshaun Watson and James Harden. But anyway, I would like to ask, since we are a multidisciplinary team here, is TAVR introduction was the best. We started with the high-risk patients, intermediate risk patients, to low-risk patients with real randomized clinical trials. Should we be doing the same thing for valve in valve? Or do you think now the evidence is enough without a randomized trial to just go ahead and make it our regular routine practice rather than go through rigorous randomized trial? And I would really like to hear the surgeon, Dr. Caselli's opinion, Dr. Silva, and interventional cardiologist turned non-invasive cardiologist, Dr. Pinero.
Yeah, I'm not sure I have an exact answer. I think it's on a case-by-case basis. In a very good risk patient, the reoperation on an aortic valve carries a little bit, but not a great deal more risk than a primary operation. There's no question that the low-risk trials showing that the short-term and medium-term benefit of TAVR in these patients is safe and effective, and it also applies for valve and valve. There's some limitations. Eventually, if you start out with a young patient and you go valve and valve and then valve and valve and then valve and valve, you get out to a point where now you've got an old patient who's high risk, and you've sort of run the course of what valve and valve can do. And maybe at a younger age, you should sort of at least consider, the possibility of positioning that patient for getting to that older stage and not being limited by their options. But by that I mean, in a young low risk patient, certainly, valve and valve is a possibility. But in a small annulus, for patients who do a lot of aortic root surgery or even a modest amount of aortic root surgery, aortic valve annular enlargement does not increase the risk substantially. Anything you do increases the risk some, but it's not a consequential increase in risk. And I think despite what we thought about certain valves a few years ago, I think it's incumbent upon surgeons not to place 19 and even 21 valves in most patients anymore. To go ahead and do an annular enlargement, and at least get a 23 and hopefully even a 25 valve, in these patients. We keep in mind, though, again, I guess it comes back to individualization. You've got a 124-pound, 87-year-old lady. She's not going to be running triathlons, so her requirements from a hemodynamic standpoint versus a younger patient are going to be quite different. So again, I guess it comes back to individualization. There's a lot of things that we can do, but we really need to sit back and think, is this something that for this particular patient, should we do this? I also think for an institution which has the capabilities, being able to offer all the various tools in the armamentarium allows us to make the best choices.
If I can add something here,
Sure.
We know from the data that redo surgery in valve failure, it has higher risk if we compare it to the original valve surgery. But if we compare valve procedure to the original native TAVI, it carries lower risk. So we have some data saying if this patient goes for redo, his risk is much higher than the original surgery. But if we go with TAVR and a valve, it's lower risk than the native procedure. So I think from the data we have here, it's justified to go with a lower risk procedure than higher risk procedure. The first case that we have seen today, which is really a very nice case, we had exactly similar case last week, but the VTC was 3 and the height of the coronary was 3.5. So that patient had very high risk for coronary occlusion. So we went up with basilica and we fractured the valve, which was 21. We went with 22 balloon. So at the end, we had that left main that was very close to the valve after basilica was widely open, and the gradient was 7, mean gradient was 7. I think when we start to do those cases, I think we should be, strict about getting the optimal result out of it. There is no point to do a procedure, then you end up by not getting the full optimal benefit to the patient. So I think valve is coming. The other point I want to say that we know that supraannular valves compared to the intraannular valves, they carry lower risk of gradient, less patient prosthesis mismatch if we use it in those patients. So it is, a process of thinking before you go for it. Try to maximize the benefit of that procedure to the patient.
I think what's good in these two cases is that there is a teamwork. And I think the key of success is teamwork. And I noticed, what my question is, how would you control this fracture? Because is it by the size of the balloon, by different measures like Dr. Conero has shown us, that with 26 it's safe to use a 26 balloon? What do you do exactly if something goes wrong, like a rupture or something? What will you do?
Well,
that's
the
the next to us.
Well, we do have this the studies that are the bench studies looking at when those valves fracture. Of course, the bench studies are not, most of the times reproducible. One thing is to blow a valve in air, and the other one is inside a patient that has a root and that has all this the compliance issues of an old aorta and an old annulus. Whenever you see one annular rupture, and unfortunately I have seen one, and exactly it was in an Edwards valve with an exact spicule of calcium like that in the LVOT. Once you see one, you don't want to see it again. And so I'll tell you that Joe probably remembers that case. It was really hard. He operated on the patient made out of the OR, but it's not pleasant. So I think procedure planning is key, and we do sometimes you shy away from something more aggressive with somebody that's the mid 80s, very frail, that cannot, doesn't do a lot. So we know that this patient is going to be well served with a valve, even if the valve has a little bit of stenosis. Shri, what's your take on it?
Oh, absolutely. I mean, most of these patients, the points were well taken from, with the huge experience of what Dr. Kosali has and Dr. Almari. Absolutely. All the data and everything shows that we do have a very good outcomes from the short-term results and whatnot. But as Dr. Kosali was saying, I agree that most of these patients are now in the age group of already having their valve replaced in their 60s or in their 70s, coming back to us again in their 80s. The risk of going back to the surgery is always higher, given the age and frailty and other things.
Is there a size limit for the balloon to over? When you have a 20 valve, you can go up to what, 22, 23? What do you use?
It's amazing how you would make that difference even with that small millimeter of changes. We've seen patients who have really small valve rings, and then when you expand it to one size upper, they just amazingly reduces the gradients and everything. Now, especially one point here is if it's a trifecta, you have to go for surgery, because even though you're putting another valve inside the valve, it's going to further reduce the entire orifice area. And coming back to the first case, what we presented, if you see, she's a small lady with a BMI of somewhere like 1.6, 1.7. You would expect that her valve area is going to be smaller. So the final result of 1.2 may be better than her compared to the second patient, which he would be symptomatic, but not the first one. So it all goes with what is their BSI, what is the an end result of the valve area compared to their BSA and compared to the entire heart, rather than generalizing the valve areas and generalizing the other parameters. So,
Dr. Waqar, if I can answer,
yes.
Dr. Adil.
Yeah, go ahead. Then that will be the last comment. We're being asked to
each
conclude.
valve has a pressure to fracture it. So it's not really volume, it is a pressure. So each valve from the bench test has a certain pressure to fracture. Carpenter Edwards, usually it is above 20. You have to go above 20 to fracture it. Trifecta, you can't fracture it.
You can't fracture it.
So it depends on which valve you're dealing with. I have one trick that we're using in valve fracture with the indeflators. I have seen the operator pushing the indeflator, and they go to the other one. What we do here is we use the big indeflator, the 29 Edwards indeflator that has no gauge, and use another one with a gauge, and we keep the gauged one locked, open to 3 ways, and then we push the big one until we feel resistance, lock it, and just torque it, and follow the pressure on the other side. So all the time you use one indeflator, and until you fracture it. Once you fracture it, you pull both together. This is a trick that we use, so just share it with you.
Thank you very much. We'd like to thank our friends from Houston, Texas, for joining us, and early in their morning, and we'd like to continue with our program, so we will close this session. Thank you, everybody.
Thank you.
Thank you. Thank you.
Thank you.